I am now starting the modules on pediatric hematological disorders. In this, I'll be discussing about important relevant disorders in pediatric hematology, which includes anemias in children and bleeding disorders in children. Please note that I will be covering the clinical hematology part, where I will be focusing more on clinical features and management of the condition rather than the laboratory investigations. So, for this, you are advised to read it along with your pathology modules also, where you will study more about the laboratory findings in hematological disorders. So, with that introduction, we will start anemias in children. First, you should know what is the definition of anemia. It's a definition given by WHO as a cutoff. Cutoff hemoglobin. In terms of grams per deciliter. And as I have written, it depends on the age of the child. For example, the child is 6 months to 5 years. The cutoff is 11 grams per deciliter. So hemoglobin less than 11 is considered as anemia. Then 5 years to 11 years. Cutoff is 11.5. So value less than 11.5 grams per deciliter is considered as anemia. And in children more than or equal to 12 years, cutoff is 12 grams per deciliter. So please remember, the cutoff of hemoglobin is according to the age group. This is a standard WHO definition. Next, I am going to tell you about approach to anemias in children. This is a general approach to anemia and not a specific approach. Please remember, most of us have an impression that only with lab testing I can narrow down the cause of anemia in a child, but it is not so. A careful history and physical examination will help you to narrow down the diagnosis with very few lab testing. That is what I am going to discuss now. Okay, it would be a simplified approach based on a combination of clinical and lab features. First is about the careful history. Remember, in children, diet history is very important because nutritional deficiency, especially iron deficiency, is the commonest cause of anemia in children. So careful diet history is very, very important. You should also ask for history of any chronic diseases like a chronic liver disease or a chronic renal disease. That history is very important because anemia of chronic disease by itself is a separate entity which is associated with anemia in children, though it is relatively rare. The third important history is to ask for the history of hemolytic disorders. History suggestive of a hemolytic disorder. And this history would include history of jaundice or family history, very important, family history of anemia or jaundice, family history of gallbladder, GB, gallbladder disease like gallstones, and family history of splenectomy. These are all pointers which would tell you that there is a possibility of hemolytic disorder in the child. Okay, why I am saying that family history important? Because many hemolytic disorders are inherited hemolytic disorders. So these are the things which you should concentrate in the history while approaching a child with anemia. Next is very, very important is focused physical examination. In physical examination, you have to look for associated congenital anomalies. Associated congenital anomalies. This is noted in conditions of congenital anemias, like in case of congenital aplastic anemias, which I am going to tell you further. The name of that is Fanconi's anemia. That Fanconi's anemia is associated with other congenital anomalies as well. That is why you should look for associated congenital anomalies. So that is one important part of physical examination. Second important is to look for evidence of petechiae or purpura. We all know that petechiae or purpura are a feature of associated thrombocytopenia, which could be noted in conditions like leukemia, aplastic anemia, You know that in aplastic anemia, all cell lines will be decreased, as a part of which platelet count is also decreased, or it could be a feature of HUS, which is hemolytic uremic syndrome. Okay. Third, you look for evidence of lymphadenopathy. It is not just a single lymph node, but generalized lymphadenopathy. Which is again a feature noted in leukemias as well as in some inflammatory conditions like systemic onset JIA. Systemic onset JIA, that is juvenile idiopathic arthritis. That is what is JIA. So generalized lymphadenopathy is another important finding. Fourth is splenomegaly. Splenomegaly is again noted in association with conditions like leukemia and in conditions of hemolytic disorders. Very, very important. We are going to look further hemolytic anemias, and most of the hemolytic anemias, one important physical examination finding is always splenomegaly. So that is important. So these are the focused physical examination finding which can tell you the associated problems in a child with anemia. So that is about the clinical history and physical examination. Next, moving on to approach based on laboratory findings. As I have told you, this is only a simplified approach which we follow in clinical discussions. First, start with a parameter called MCV. What is MCV? It is mean corpuscular volume. You should know what is a normal value of MCV. It is expressed in terms of FL, which is femtoliters. It is 90 plus or minus 8 femtoliters. And based on MCV, we can divide the anemia groups into two. One is low MCV, that is low mean corpuscular volume, which is called as microcytic anemias. The other one would be MCV, which is normal or high. High MCVs obviously would be called macrocytic anemias. Okay, right. The conditions which are associated with microcytic anemias include 3 in number, as you must have read already. One is IDA, which is iron deficiency anemia. Number 2 is a condition of ACD, which is anemia of chronic diseases like chronic renal disease or chronic liver disease like that. So anemia of chronic disease. Third is thalassemia. These are the 3 main categories under microcytic anemias. So how are you going to approach this category further? This is based on a proper history plus physical examination. What we are going to look for is the history and physical examination suggestive of iron deficiency anemia. Suggestive of iron deficiency anemia. Okay, I have not told you about the important physical examination findings in iron deficiency as well as relevant history. But as of now, for approach, we can just generalize and remember. If the history and examination suggest of iron deficiency anemia, then what you do is you give a trial of therapeutic iron. Therapeutic iron. And after that, you look for the response. If there is a good response, then definitely the diagnosis is iron deficiency anemia. If there is no good response, you have to evaluate further. What are the other 2 categories which are left? Yes, it is thalassemia and anemia of chronic disease. So you have to evaluate in those lines. Okay. Now, one investigation which will help you in narrowing down the diagnosis could be ferritin levels. So what does the ferritin levels indicate? In iron deficiency anemia, ferritin levels are characteristically low, and one of the most important investigation we perform in iron deficiency anemia. Next, ferritin levels are normal in case of, usually normal in case of thalassemia, and ferritin levels are high in case of anemia of chronic disease. So this ferritin would help in further distinction of the three causes of microcytic anemias. So this is the approach to low MCV anemia or microcytic anemia. Next is based on MCV, which is normal or high. In this, the starting point is reticulocyte count. You divide it into two categories. One is low reticulocyte count, other one is high reticulocyte count. Please remember, if it is a high reticulocyte count, what you know always, it is usually seen in case of hemolytic disorders, or following a blood loss, there can be high reticulocyte count. That is what we have already learnt. So we are going to approach this whether it's a hemolytic problem or following a blood loss problem. That's all. For this, you are going to do the next step, that is peripheral smear. Peripheral smear, where basically I am going to look for evidence of hemolysis. Okay, if hemolysis is present, then definitely I have to think and evaluate in terms of hemolytic anemias. Yes, hemolytic anemias. Okay. If there is no hemolysis, there is no evidence of hemolysis, then what is the other condition I am looking for? Some condition which is characterized by blood loss. So I have to evaluate in terms of conditions characterized by blood loss, like for example gastrointestinal bleeding, chronic GI blood loss. Okay, I have to evaluate in that line. This is an approach for high reticulocyte count. Next is the approach for low reticulocyte count. Here again I have to look for peripheral smear. Again peripheral smear to look for evidence of hemolysis. Again, if there is evidence of hemolysis, then I have to strongly consider hemolytic anemia. Now you may be thinking about one question. What is that? Normally I am expecting high reticulocyte count in case of hemolytic disorders. Why in this scenario there is low reticulocyte count? It is because in many of the hemolytic disorders there is a condition called aplastic crisis. Aplastic crisis, which is usually precipitated by an infection, commonly parvovirus B19 infection. What happens? During that aplastic crisis, the bone marrow is suddenly shut down. It will not produce any of the cells, resulting in pancytopenia, as a part of which there would be low reticulocyte count. That is how low reticulocyte count can be encountered in a scenario of hemolytic disorders. Okay, so that part is clear. What is the other part? Where peripheral smear shows no evidence of hemolysis. Okay, then you have to check for the counts or the levels of platelets and neutrophil. Platelets and neutrophil count you have to check for. If they are low, then it means RBC is low, that is why there is anemia. Platelet is low, thrombocytopenia, as well as neutrophils are low. It means bone marrow is not practically producing the blood cells. So in this situation, what could be the diagnosis? It is condition of BM, that is bone marrow failure, which is encountered in conditions like aplastic anemia, or in severe cases of megaloblastic anemia also you encounter pancytopenia. So megaloblastic anemia is also a possibility when all cell counts are decreased. This should be remembered. Finally, if the platelet count and the neutrophil counts are normal, only RBC is decreased, then it is called as pure red cell aplasia. It is called pure red cell aplasia. This could be a very rare condition. Again, it's a congenital condition called as a Blackfan-Diamond syndrome. So this is the approach based on MCV. This is the simplified approach to anemia in children, which I have given with reference to lab values. So as I have said before, based on a careful history and physical examination along with minimal investigation, you should be able to narrow down what is the cause of anemia in a given child. Clear? Okay. Now I am going to look at individual disorders causing anemia in children. First, starting with nutritional anemias, and in that, iron deficiency anemia. We all know that iron deficiency anemia is the most common condition causing anemia in children worldwide. Very, very important fact. It is a most common condition. Okay, or most common cause of anemia in children worldwide. Now, what is the meaning of iron deficiency? Iron deficiency is a state of insufficient iron such that it is not able to maintain, unable to maintain the normal physiological functions. Unable to maintain normal physiological functions of iron, and also characterized by low levels of iron stores in the body. This is what is the complete definition of iron deficiency. Okay, right. So important factor is iron stores. And we all know that one of the storage forms of iron is ferritin. That is why even in the previous discussion itself I told you iron deficiency anemia is characterized by low ferritin. One of the very, very sensitive tests which we can do in a child with suspected iron deficiency anemia. Okay, right. Now let us see what are the reasons why a child should develop iron deficiency. Now let us look at what are the risk factors for development of iron deficiency. Okay, number 1 is dietary deficiency. Okay, and number 2 is conditions where there is increased demands of the child. For example, at the time of growth spurts. We all know that growth spurts normally occur in the first 2 years of life. That's what we have learnt in the chapter of normal growth, right? First 2 years, and around the time of puberty also there is a growth spurt. That is why these two age groups you see high incidence of iron deficiency anemia. Okay. Now a specific point about the first 2 years. It is not from birth onwards a child is at risk of developing iron deficiency anemia. Very, very important point. Why? Because a newborn baby has good amount of iron stores which the baby has acquired from the mother during the last trimester of pregnancy. Very, very important point. So that is why in the first few months of life, okay, till the first 6 to 9 months, the child does not develop iron deficiency anemia even if the diet is low in iron. Why? Because of the protection afforded by the iron stores. That is why if there is a question, what is a typical age group at which iron deficiency anemia is noted? Please answer, it is 9 to 24 months of age. Okay, this is very, very important for your exams. 9 to 24 months is a typical age group. Why not in the first few months? Because of the protection given by the iron stores. Straight and simple. Very important. The next group of children who are prone for iron deficiency anemia are babies who are born as preterm babies or low birth weight babies. Especially very low birth weight babies, which refers to a weight of less than 1.5 kilograms. Why do you think so? In this group, iron stores is very, very less. That is why they are prone for developing iron deficiency. So the reason is iron stores are very, very less. Okay? Yes. The fourth important risk factor is malabsorption. A typical example of malabsorption associated condition where you can have iron deficiency is conditions like celiac disease, where the small intestine is affected, thereby iron absorption is decreased. And fifth important condition is hookworm infestation. Hookworm infestation. This is supposed to be one of the leading causes of iron deficiency. Okay, there are multiple factors which are implicated. One of the common factors is they predispose to blood loss from the intestine, thereby predisposing to anemia. They can also be associated with a component of decreased absorption of iron. So these are the factors which make hookworm infestation a very important cause of iron deficiency anemia. And always remember that while you treat children with iron deficiency anemia, to tackle this hookworm infestation, you have to give 1 dose of albendazole or what is called as deworming. Okay, right. So that those are the important risk factors for iron deficiency anemia. Now let us look at what are the features of iron deficiency anemia. Of course, due to anemia, the child looks pale or there is pallor. Associated with that, there can be irritability and fatigue, easy fatigue. These are the usual features, not only for iron deficiency, any condition causing anemia in children. Okay. Next, some of the peculiar features of iron deficiency anemia is what you see in this picture. Can you see that the nails are something like curved like this, something like this? This is what we call it as a spooning of the nails, or what is called as koilonychia. Another characteristic feature of the nail noted in iron deficiency anemia is platynychia. Platy refers to flatness, so it is basically a flat nail. So these are some of the unique features of iron deficiency anemia that one can correlate with. Other features include manifestations in the mucous membrane, like you can have glossitis, angular stomatitis. Again, this glossitis and angular stomatitis are not specific features for iron deficiency anemia. They can be seen in other causes of anemia or other nutritional deficiencies also, especially riboflavin deficiencies. So these are the usual features of iron deficiency anemia that one should know about. What are the important association? Okay, this is an important or a star topic. Why? Because questions have been asked previously. Okay, associations of iron deficiency anemia. Some of the behavioral disorders are included. These are pica. Okay. Number 2, temper tantrums. Number 3, breath holding spells. And last one to that list, please add restless leg syndromes. So these are the 4 important associations of iron deficiency anemia that you should be knowing about. Next is about lab features of iron deficiency anemia. Again, I'm just going to give you only overview about the lab features. The most important features are microcytosis, small RBCs, anisocytosis, okay, low MCV, and low serum ferritin. These are the characteristic lab features in iron deficiency anemia. Now coming to the treatment of iron deficiency anemia, please remember that oral iron is usually preferred for treatment. There are so many formulations of iron available, but the most effective and the most economical form of iron is ferrous sulfate, which contains 20% of elemental iron. An important MCQ question. How much is the percentage of iron in the ferrous sulfate? It is 20%. Okay. What is the dose of iron? Okay, for the treatment, it is 3 to 6 milligram per kilogram per day. The duration of iron treatment is for a period of 4 to 6 months. The main reason for this longer duration of treatment in iron deficiency anemia is because you have to replenish iron stores, which will take many months to occur. That is why you are giving 4 to 6 months of treatment. Next, after you have started iron, okay, treatment, how to look for response in that particular child, whether the child is responding to treatment or not. It is given by various timeline, and this is one of the commonly asked MCQ questions in any competitive exam. Response to iron treatment. Okay, it is given as a timeline, as I said. The first 12 to 24 hours, what is expected is subjective improvement. Very important. It is subjective improvement. The subjective improvement would be in the form of decrease in irritability of the child. Child feels better. Okay. Next is appetite of the child improves. These are the subjective improvement that we need to look for. Next is replacement of intracellular iron enzymes. Okay, there are certain enzymes inside the cell which are dependent on the iron. They will be replaced or replenished. That is the next response which we need to know about. Then by 36 to 48 hours, okay, the bone marrow response is noted in the form of increased number of erythroid cells in the bone marrow, or what we call it as erythroid hyperplasia. Erythroid hyperplasia. Don't forget. Okay. Next, 48 to 72 hours. This is where reticulocytosis happens. Reticulocytosis. It starts by 48 to 72 hours, but it peaks by 5 to 7 days. And this reticulocytosis response is again asked in one of your previous exams. So should make a note of it. By 4 to 30 days, there is an increase in the hemoglobin. Hemoglobin level starts increasing by 4 to 30 days. And what is that? Last 1 to 3 months, very, very important, there is replenishment of iron stores. It will take few months, as I have written here. That is why I was telling you that the duration of iron treatment should be for many months. Okay, to be on the safer side, we give it for an even longer period of 4 to 6 months. Ensure that iron stores are fully replaced. That is the point to be highlighted and remember. These are the various aspects of management of iron deficiency anemia. Next, we are going to look at megaloblastic anemia. We know that megaloblastic anemia is a condition characterized by large cells or macrocytes, which is the name given for big RBCs in the circulation. Megaloblast refers to the big RBC precursors in the bone marrow. Okay, now this is a condition basically due to delay in the nuclear maturation of the erythroid series. Generally, when we talk about maturation of the cells, we talk in terms of nuclear and cytoplasmic maturation. In megaloblastic anemia, it happens to be delayed nuclear maturation. That's a question previously asked which you should know about. Now let us look at what are the causes for megaloblastic anemia. We'll divide them into B12 deficiency causes and folic acid deficiency causes. B12 deficiency causes, number 1 is the diet. Please remember, it's a pure vegetarian, or what we call it as the vegan diet, which predisposes to B12 deficiency. Okay. Next is a condition called pernicious anemia, which is a condition characterized by autoimmune antibody mediated damage causing deficiency of intrinsic factor. IF is intrinsic factor, which is needed for absorption of vitamin B12. Okay, so that is the second condition. Third condition is conditions of malabsorption, which is noted in conditions like Crohn's disease, which is a form of inflammatory bowel disease. Chronic pancreatitis, it can be noted. And also with a specific infection by the fish tapeworm. What is that called? Diphyllobothrium latum. Diphyllobothrium latum. These are the common conditions in this category. The next group of condition is a rare group of condition but important from the MCQ point of view, called as metabolic disorders associated with B12 deficiency. These include 3 main disorders. I'll put a star for them because it's an important question for you. They include homocystinuria, orotic aciduria, and one more is MMA, which is methyl malonic aciduria. These are the important conditions associated with vitamin B12 deficiency. Moving on to the other category, that is folic acid deficiency. It is also related to dietary factors. An important dietary factor here is excess consumption of goat milk, which is found to predispose to folic acid deficiency. It can also be associated with malabsorption conditions as well. And in this, an important parasitic infestation predisposes. What is that? Giardia infection. Very important. Now, in the previous discussions, I have told you some important infections associated with few of the anemias. What is that? Hookworm infestation for iron deficiency anemia. Just before I have told you Diphyllobothrium latum infection for vitamin B12 deficiency and Giardia infestation for folic acid deficiency. Don't forget, these three are potential MCQs. Okay, right. It can also be associated with condition characterized by decreased utilization or metabolism of folic acid, and this is usually associated with the drugs. Important examples of drugs in this category include 6-mercaptopurine, methotrexate, as well as the trimethoprim. These are the usual cause of folic acid deficiency. Now, let us look at what are the features of megaloblastic anemia. Again, these patients will have pallor, as a result of which tiredness or fatigability as well as irritability can be present. Okay. Next is some characteristic findings associated with megaloblastic anemia, because pallor is a non-specific feature. Any type of anemia, you get it. But characteristic of megaloblastic anemia includes smooth, beefy, red tongue. Very, very classical description is beefy, red tongue. Okay. Next one, they can have hepatosplenomegaly. In 30 to 40% of cases. They can also have hyperpigmentation, especially in the knuckles and in the back of the fingers. That is also characteristic. And last is regarding the neurological manifestation. Now please remember, neurological manifestations are usually noted with B12 deficiency cases of megaloblastic anemia. And very important point is, these neurological manifestation can occur before the onset of anemia also, or they can precede anemia. Okay, they can precede the occurrence of anemia. The characteristic manifestation in this include loss of position and the vibration sense. This is supposed to be the earliest manifestation, earliest neurological manifestation. That is an important MCQ question by itself. And the other manifestation include unsteadiness of the gait and abnormal sensations or paresthesias. These are other neurological manifestation. Okay, these are the common clinical features associated with megaloblastic anemia. Now coming to the lab features, just a quick note. This will be characterized by macrocytes in the peripheral smear, or big-sized RBCs, what we also call it as macro ovalocytes. Other features include the characteristic hyper-segmented neutrophils, where they have 6 or more lobes in the neutrophils. These are characteristic lab features which you can see in the peripheral smear of a patient with megaloblastic anemia. Now coming to the treatment aspect of megaloblastic anemia, depends on what is the cause, whether it is folate or B12 deficiency. When you are not sure about the cause, it is recommended that you give both folate and B12 as a treatment part. Okay, regarding the folate or the folic acid, the dose is 1 to 5 milligrams daily. It is given for a period of 3 to 4 weeks. That is the duration of treatment. Okay, for B12 deficiency, there are so many treatment regimes which are followed. I'll tell you the common one which is sufficient for most cases of B12 deficiency associated megaloblastic anemia. It is administering 1000 micrograms of B12. Remember, there are oral formulation as well as parenteral preparations of vitamin B12. It is found out now that oral preparations are as effective or as efficacious when compared to IV preparation. So nowadays oral preparations are preferred. That is a point to be noted. Now you give this 1000 microgram daily for 2 weeks. Then you give the same dose 1000 microgram weekly, that is once a week for the next 2 weeks. And then 1000 microgram monthly, that is once a month, usually for a lifetime. This is the usual treatment regime followed for megaloblastic anemia. So that is about the two important nutritional anemias which I have discussed, namely the iron deficiency and megaloblastic anemia due to B12 deficiency and folic acid deficiency. Next is a group of condition called inherited pancytopenias. Pancytopenia is a condition characterized by decrease in all cell counts, like decrease in RBCs, WBCs, as well as in platelets. This is what we call it as bone marrow failure syndrome. That is, bone marrow is failing to produce any of the blood cells. And what I am going to discuss about is only inherited condition causing pancytopenia. And the classical example of this is a condition called Fanconi's anemia. Fanconi's anemia. This is a condition which is inherited as autosomal recessive disorder. Very important point. The basic defect in Fanconi's anemia is a defect in DNA repair. Okay. That is why in Fanconi's anemia, if you look at the cells, these cells have unusual chromosomal fragility, or what we call it as a chromosomal breaks. This is basically because of defect in the DNA repair mechanisms. Very simple. Okay. Now, moving to the characteristic clinical features of Fanconi's anemia, please remember they will have pancytopenia. So what happens? Due to decreased RBCs, they will have pallor. Due to decreased WBC, there is an increased risk of infections. Third is due to platelet decrease. They also have bleeding manifestations like petechiae and purpura. This is directly related to pancytopenia and Fanconi's anemia. The next set of features are associated features, which are usually remembered as 3S. Okay. First S is for the short stature. The next S is for skeletal anomalies. And the classical skeletal anomaly which is associated with Fanconi's anemia is remembered as radial ray defects. Radial ray defects, typical examples include absent or hypoplastic radius or the thumb. That is a classical defect. Don't forget the name, radial ray defects. Okay. And the third is skin pigmentation. The characteristic manifestations include hyperpigmentation. It's a generalized hyperpigmentation of the skin, as well as presence of few localized hyperpigmented spots or the macules. What are they called? Caffulae macules. Very important. This association with Caffulae macule has been asked once in your previous exams. So Caffulae macules. Don't forget, it is important. So these are the 3S that I want you to remember. In addition, other feature of Fanconi's anemia is the facial appearance, where these children have microcephaly with a small jaw, or what I am going to write as tapering jaw. These are the usual clinical features of Fanconi's anemia. This picture tells you about the characteristic findings. You can see that in this first picture, it's an older patient with Fanconi's anemia where he's having the narrowing of the jaw or the tapering of the jaw like this. This is the tapering of the jaw. Okay, right. Next picture shows the radial ray defects, where I told you some thumb defects can be present. These patients can have different varieties of thumb defects. I told you they can have hypoplastic thumb or aplastic thumb. This picture tells you one more feature of radial ray defect, which is bifid thumb. That is, thumb is like two fingers, okay? So it's called bifid thumb. This is also another anomaly which is associated, okay? The third picture shows the characteristic chromosomal breaks, okay? You can see that this is the chromosomal analysis where you see lot of breaks or cuts in the chromosome. That is what I mentioned as chromosomal fragility, which is a characteristic feature of this particular condition. Again, revise. What is the reason for chromosomal fragility? It is a defective DNA repair. Now, coming to the treatment of Fanconi's anemia, please remember the usual or the best treatment possible for these children is HSCT, which is hematopoietic stem cell transplantation. Okay, of course, with the HLA matched donor, the success rates are very high. That is the usual best treatment for these children. If HSCT is not an option or it is unavailable, then you go for a palliative treatment in the form of oral androgens. Okay, not to forget, you should also plan long-term follow-up of children with Fanconi's anemia because they have increased risk of AML, acute myeloid leukemia, as well as cancers in other parts of the body, especially oral cancer and liver cancer. So that is why these children, they require long-term follow-up. These are the salient features of the inherited pancytopenia associated with Fanconi's anemia.